Hello and welcome to this new series of our Quantum Way Chronicles. It's a very special one. It's a South African chronicle, and I'm here in Cape Town at the Stellenbosch Hospital, the Department of Psychiatry and Child Psychiatry, with an incredible guest, Anusha Lachman. You are a psychiatrist, a child psychiatrist, and I'm really, really happy that we're gonna go over everything you're doing here and the specifics of South African child psychiatry and the challenges you're facing here. So thank you for being here. And,
thank you for having me.
For inviting us in your environment, in your office, in your hospital.
You're very welcome. Yeah.
So let's know what you're doing. What are your specifics, or what have you worked on recently?
So, like you said, I'm a child psychiatrist, but I work on two ends of the spectrum. So, I clinically work a lot with adolescents. I run a unit for adolescents with severe mental illness, for neuropsychiatric illnesses, and trauma-based responses at a public hospital, which is Tygerberg Hospital here in the Western Cape. But as part of Stellenbosch University, I also run a master's program for infant mental health. And that involves primarily education, training, teaching, and advocacy for infants and caregivers in this environment. So I lead that program, and I lead the research group on early infant mental health and early intervention in low middle income settings based in our department.
So we can take both ends of the spectrum. So let's start with adolescence, because it's really the core of your work here. What do you encounter, and what is specific to South Africa?
I think South Africa has so many layers of historical trauma and complexities that we often misunderstand the need. We underestimate the impact of transgenerational trauma, but also exposure that adolescents, that young adults, for example, have on a daily basis in an environment and in a context that's so different from anywhere else. And so, for example, we are at a tertiary unit where, in addition to us seeing this, I want to say, standard psychiatric mental illnesses that express themselves at this time in life, we also have to deal with a really complex environment that is colored by lots of exposure to gang-related violence. We are in Cape Town. We have high rates of mental illness, high rates of neurodevelopmental risks. So, for example, fetal alcohol syndrome, for which we have the highest rates and prevalence in the world. We have postpartum depression in mothers, where we have a 3 times higher prevalence rate again than anywhere else in the world. So we're sitting at a melting point or melting pot of risk and exposure to adversity. So when we admit adolescents, we have limited beds, limited resources, but we also have limited opportunity in which to intervene in a way that is speaking to the context-specific limitations that adolescents face. So that's the core of the work that we do. And every day is both a privilege and a challenge, where we're having to navigate in really difficult circumstances. What are the best evidence-based treatments? Where do they come from? How able are we to adapt that in a way that's respectful to the community, to the culture, and to the context? And one of the things I often struggle with in reaching international students, and even people from outside of Africa, is to remind them that Africa is not one place, and it's not one people either. So we look different, we come from different communities, but we all have an intrinsic African heritage, and in South Africa specifically colored by our colonial past, but also our apartheid past. And that's the generational trauma that we see expressing itself in the challenge of managing these complex mental health conditions.
How do you see this transgenerational, or these historical traumas, how do you see them in maybe the symptoms that you are seeing in adolescence, and how they carry that today, because they haven't known anything about, they don't know apartheid, they weren't there at the colonial times, but how do they carry that still now?
South Africa remains one of the most unequal countries in the world. There's no exception when it comes to children carrying the burden of that historical trauma. So if we think of the adolescents that we see, the privilege divide is stark. So you may be from a particular community, for example, that is not historically white or English or Afrikaans, but you are the majority world in South Africa. You may be, if we think traditionally, our race categorization in apartheid times, which was Black, Indian, colored, Chinese, even of that ethnicity. Even within those subcategories, there's a difference in privilege and disadvantage. And so how we see that meter out is that children across the spectrum, despite there being on paper or laws that protect or allow access, children are not all equal. And so when I see a child who comes to us with a suicide attempt or suffering from schizophrenia or bipolar, it's never a simple list or an algorithm to follow to say, here's the medication, here's the therapy, and now you respond, you go back. We have to think in the context of what do you go back to? And that's where you see the legacy of apartheid. So you go back to either an informal settlement or an environment which has lots of exposure to gang-related violence, or an environment with food insecurity, or parents who themselves were unable to complete school, unable to overcome substance use and dependence, unable to parent in a way that is nurturing. And so that's how it translates out. When people say, well, you know, you were not even born in apartheid. Well, you live with the consequences of it, with a society that hasn't been able to integrate your parents or your grandparents in a way that's fair and that allows them to support you. We often also see that there have been many attempts. We work for the government, for the Department of Health, and we see many attempts that the government has made to allow equal access to education, for example, to healthcare. But within those educational initiatives, for example, within healthcare initiatives, there's still a concern in terms of the haves and the have-not. And it's not a simple divide according to race. It's even within racial groups that there's privilege. And so children are the kind of torchbearers to that legacy. So in a really roundabout way, coming back to say that it's never that simple. When I treat a child for a substance use disorder or dependence in the context of a psychotic illness, we might offer them the best treatment we can, and we have many treatments available, medication and psychotherapy, and I might reintegrate them into school. But when I discharge them into an environment and a community that hasn't recovered from the injustices of apartheid. There still are schools that are different 15 kilometers away from our university. We still have environments where children are living in overcrowded conditions, where you might have this wonderful rehabilitation experience in a psychiatric institute like ours. But when we go out, we've done nothing when it comes to protecting you from sexual violence, educating the environment, the public, or protecting your school from gang-related violence, from bullying. So I think it's very complicated. And the reality is, in our environment, I have yet to come across a child who presents almost with a clean bill of health. Yes, you have your adversities, you have your vulnerabilities to mental illness, but you have the psychosocial determinants of mental illness that really have nothing to do with your willingness to get better. You're a product of that environment. That environment is a product of the history. So I think that's what makes it different. It also allows a lot of opportunity, but also is not without its challenges.
You're an advocate of Afrocentric interventions or cultural sensitive interventions. And I'm wondering, you talk about those adolescents that you treat here that are in a good, environment, people taking care of them, they get the good medication. But when they go home, what are those interventions that are Afrocentric or cultural sensitive that you give here, but also that you try to get out of the hospital, and how we help those young who go back to their environment that can be really, really challenging?
I think it's a difficult question to answer simply, but maybe if I can give you examples in our hospital, for example, we always have to reflect on the practice that we follow. And so the easiest way to say is when you are in a medical environment, one imagines that you would follow what is accepted evidence-based information. And you say, this is the treatment, and this should work as a gold standard wherever you are. And so we're providing healthcare that is evidence-based. And I challenge you, or, kind of people who train with us, to say, let's take a step back and let's ask ourselves, is that really the best evidence? What's the next best thing? And so I'll give you an example that kind of speaks also to the other work we do, which is infant mental health, where we really advocate for the Afrocentric approach. So many children that we see in our environment, in our hospital, are children who are not brought up by their biological parents. It's such a fundamentally important concept to understand. A lot of our interventions, a lot of the studies, a lot of the evidence-based treatment may be holistic. We use all the fancy words and we say that, we're not just medication, we're providing psychotherapeutic interventions and social interventions. But again, I'll challenge you to say, let's think about it in simple terms. Let's talk about the mother and the baby, the child and its parent. Who is looking after this child? Unfortunately, in South Africa, most mothers have to work looking after other people's babies. So as a result, babies, children, adolescents are often looked after by other people who are still primary caregivers, but not relatives. So they may be grannies, yes, of course, but more often than not, there are domestic workers, there are house helpers, there are creche teachers, they are helpful aunties and neighbors in the environment. And so when this child has a mental illness or a physical health condition and they come into this hospital, legally, for a child to receive treatment, they need to be consented. And so we ask for the biological relative, usually the parent, to consent. And we never ask, is the biological parent the same person that looks after the child? Because it almost doesn't make sense to you. People are like, what are you talking about? It's the parent. They look after their child. And that is the fundamental flaw in the understanding of when you're treating children. Because you have to appreciate that in this environment, most children are not looked after by their biological parents. So when we're trying to do an intervention, we really have to question, who are you directing the intervention at? Are you directing it at the mother-baby, the mother and the child, or are you directing it at the caregiver, the person who provides that quality attachment relationship to the child? And that, I'll give you a practical example, which is a study we did in our environment at Tygerberg Hospital. Was we wanted to see if babies had a different response to their pain requirements post elective surgery for an ENT operation. So simple tonsillitis. So simple ENT surgery, like a tonsillectomy. So many children have the need to have a tonsillectomy. They get their adenoids removed. And so the anesthetists asked us to help. And they said, should we have the mother in theater with the baby before anesthesia? And so the question was, why would you ask that question? And they say, well, the babies look at the caregiver and the parent and they are, distressed and they're crying and it's a scary environment. And so we need them to be calm and we need them to have a good preoperative experience so that we know if they've had a good, gentle, calming preoperative experience, their pain threshold postoperatively and their need for that kind of intervention is less. And so it makes sense. And so the question I asked back, and which led to our study, was to say, well, depends on who the parent is. And is the parent that caregiver? And so the surgeons ask, what do you mean? It's the parent. And that for me is such a good example of actually no. Because when we're in Africa, we can't just assume that the person who signs the consent form, who pays for the operation, is necessarily the caregiver. because it's not always true. And so the important thing in terms of practice and in terms of being Afrocentric in a way is to say, let's ask the question, are you the person that the baby sees every day? Are you the person who comforts, who looks after this baby when they are in pain? Because if not, then maybe you're not the person who should be the last face that the baby sees before they undergo their anesthetic induction. Is there the person who is looking after the baby around? Could they come in instead and be that comfort? And so what am I talking about? I'm talking about attachment. I'm talking about that secure relationship where a baby feels scaffolded and a baby feels able to trust the adult to keep them safe, to act in their best opinion, in their best interest. But the difference is, in our context, you need to ask, who is that person, without making the assumption automatically that it's the biological relative. So I think though we have lots of little examples like that where thinking innovatively, we always talk about we think in a context-specific, culturally respectful way, that we have to have these innovative interventions. And again, I always say, if I tell you what's innovation, immediately we're so bombarded with the idea that innovation means tech. But in a teaching hospital, in a university, in an environment where we're trying to promote more context-sensitive appreciation of the care, understanding of the psychological mindset, if we're looking for psychosocial determinants, then we also have to ask ourselves, what do we mean by that? And we don't always mean the same thing. So, I have lots of examples of how we try to teach in a way that's innovative. And innovative for me means context-specific. Teach differently. Teach in a way that speaks to the environment. Is there an alternative way to get that information across? How do we communicate in a way that's respectful, that gives the assurance to the caregiver and to the child that I see you, but I don't see you as just another child. I see you as a child, as a parent, as a family, in the context that you live in. And that for me is rethinking medical education, for example.
And it's also rethinking the Western way of understanding attachment or understanding mental health.
Yes, absolutely. There is a big move internationally. We know that when we think of global mental health initiatives, global health and public health, which are really buzzwords everywhere, it's about the fact that we're not necessarily just discarding and disregarding years of good quality research that originate from the West. We're basically saying, can we also take a pause and ask ourselves, is there opportunity for reciprocal or bidirectional learning and teaching? And I think we have a lot that we can learn from the West, who come with years of experience and expertise. But similarly, there is a lot, I think, that can be taught from our environment that you might be quite surprised. The world is not the same place it used to be 20 years ago. Mm. We have mass migrations, we have refugees, we have war, we have people that are seeking asylum in environments that are completely different to where they were brought up. And so it is in our best interest of providing care as care practitioners that we understand different contexts. And how do you do that? You don't do that by kind of swooping in a very paternalistic way and saying, let me see how I can take my evidence-based teaching, training, education, and privilege and adapt it to the environment. Actually, no. The way to do that is to say, is there a way I can learn from you? And can we, in a almost reciprocal way, be able to do what's best for our patient population? And that's kind of a lot of what we're trying to do. So if I can give you an example, if we talk about infant mental health, which is the other hat that I wear. So it's a really fascinating field to be in because it allows so much opportunity for intervention, but also, we talk about how early is early to intervene and when is it too late. And the literature will tell you, especially if you read a lot of attachment work, they'll say, there's no magic age. You want to always encourage that environment and that support and love and nurturing care. But early means early. And so we know that the science of early development tells us that when you intervene in the first 1,000 days, that's having the most beneficial impact, where adversity can be much worse, but also intervention has maximum benefit. So when we think about that, it's also still not that simple to say that the same thing applies everywhere. And when we were thinking with our group at Stellenbosch University and we were talking about infant mental health, we said, what are the things that we need to really interrogate? So yes, we understand about attachment. We know the neuroscience of development. We know how trauma and early adversity impacts the structure of the brain, the epigenetics of the brain, the way we recognize affect, the way we process trauma. We know that. And that's standard science that we can prove. But what are the things that are specific in our context that's missing, that nobody is offering that opportunity to rethink it? And so a really good example we had thought about was when you talk what is infant-sensitive care, what is nurturing care. So the World Health Organization tells you in their nurturing care framework that, babies need care that is mutually enjoyable, that's attentive to their needs, that makes opportunities for us to connect with them. But we also have to take a magnifying glass to what is the messaging we give to parents, to caregivers, that make them feel less than, or that force them to adapt their parenting skills and their nurturing care to an environment that looks nothing like the environment in which those interventions originated. So I'll give you an example. We often talk about putting babies back to bed. And that's a well-known slogan, and it's done really good things, mostly in Western Europe, where that is the sentiment that it reduces the rates of sudden infant death syndromes if you are putting babies back to bed. And there's neuroscience behind that. There's genetic reasons for that. And so we took a step back and we said, all right, but how does that impact in Africa? And so for that, we need to question. And so when we question, we say, does Africa look like Europe? No, it doesn't. Why does it not if we're looking in infant spaces? One of the reasons it doesn't is because, unfortunately, South Africa holds the kind of record for, not South Africa, Africa holds the record for the greatest number of preterm deliveries in the world. And so when you ask yourself why, it's because we have across Africa inconsistent access to good quality maternity care. Antenatal care is not the same. Women book late. They often aren't aware of the fact that they are pregnant. They come with a cluster of comorbidities that put them at higher risk, whether that is exposure to violence, whether that is food insecurity, that is poverty, substance use, all these things that put women at risk for developing a preterm, or basically developing a situation in which they deliver earlier than they should. Add to that they have a high risk of perinatal mental illness, which also puts them at higher risk of having an adverse outcome with their pregnancies. And so when we look at that, we say we have the highest rates of preterm deliveries, small for gestational age babies in the world. And what is the recommended treatment for that in this environment? So in low middle income countries, in limited resource settings, we know that it originated in Venezuela, that we promote kangaroo mother care. And that is basically skin-to-skin contact, which promotes development of the baby in a preterm space. And so babies bond better with their caregivers, whether that be the mother or the father, whoever the primary caregiver is. For mothers who are breastfeeding, it stimulates oxytocin. It allows them to encourage earlier breastfeeding. It's almost an incubator outside of the womb. So it's recreating that space. And so it's a well-known intervention for managing small for gestational age babies and preterm deliveries. Now, how do you do that if you encourage babies to be put back to bed? We need you to be on the chest. And so if you look at that, I'll take it one step further and I'll say, all right, so we need to encourage that. So maybe that slogan is not quite where it needs to be. But what about babies who die? Because that's why it's there. We're thinking of sudden infant death syndrome and we want babies to live. And so we ask the question, what makes babies at risk in Africa? And let's look at South Africa. Let's talk about what we know. South Africa has really high rates of babies getting injured in informal settlement fires. So why is that? That's because there isn't access to electricity. They often use paraffin burners, they use candles to keep warm, to cook food, to light up the environment. And so that's a really high risk in a congested environment where there's overcrowding. It's often a 2-room informal settlement made of cardboard or made of aluminium with 10 people living in that environment. And so you can see it's a disaster waiting to happen. So we often regularly, unfortunately, see these fires that raise to the ground, basically. And so what would make a baby less at risk in that environment? Well, if they were with their mothers. So if they were with their mothers or caregivers and they were close by and in the same bed as their caregiver, their adult caregivers, they were more likely to be saved because they would run when the adults run, as opposed to them being in a different bed, in a different room. So that would be another reason where we would be forced to question, is it really such a good idea to put babies back to bed? We took another step back and we said, what else are children in South Africa really high risk for? They're high risk for being abused. And it's not a statistic that we are proud of, but the reality is that children have high rates of child abuse, sexual trauma, for example. And when does that happen? That happens when children are in unsafe environments where the adults come in intoxicated, or they are distressed, or they themselves are kind of unable to be able to resist the urge to hold themselves back. And I don't mean hold themselves back in terms of sexual trauma. I mean when people are mentally ill, if they are using substances, if they are traumatized themselves, they are more likely to respond in an aggressive way, for example, or in a way that is disinhibited. If they have an untreated mental illness, they also do have challenges in terms of reality testing. All of these things put children at risk if they are in close proximity with these adults who are not able to manage that risk. And so if a baby is sleeping in a room that is shared with young adults or older adults who are intoxicated, who have untreated mental illnesses, who have high rates of trauma, they are more likely to be in the line of fire when that happens. What would prevent that? Well, if you were not sleeping in that bed away from your caregiver, who had the opportunity as that caregiver who would protect you to keep you safe. And so when we collectively looked at these, we thought, should we really be saying, put babies back to bed? And we collectively decided, no. If you are in this high-risk, adverse environment, if our priority is to protect children physically, emotionally, but also to keep them safe from harm on the outside, why not promote that without us making mothers feel bad, without us thinking, you're not following evidence-based, practice. And so that's a long example, but it's a very real example as to why we felt we needed to think differently and more innovatively about the messaging that we give to the public. So we say, sleep with your baby. Makes you feel better. It makes the baby feel better. We know that your attachment relationship is influenced by the ability of the mother to feel as if she is good enough at that point. For her to experience the baby being soothed, being safe, being able to put herself in a role that enacts that secure attachment. And so why not? And so what we started to do is we started to look at all the practices that are routinely followed, that have been created in spaces outside of this environment that I've described. And we thought, are there ways in which we can adapt? Could we suggest what's an alternative? What would be the next best thing? And so that's what we did. And so we created opportunities for education, learning, and advocacy in that space. We run a master's program for infant mental health, which I'm proud to say is the only program of its kind on the African continent that teaches exactly that Afrocentric way of parenting. Although we like to say we don't teach people how to parent, we just support and enhance practices that are culturally accepted. Our aim is to advocate for mothers, for caregivers, for fathers, for people who look after young children, to feel supported, to feel as if their culturally specific, contextually relevant ways of parenting is okay. And then we also decided that it wasn't enough for us to just have a master's program.
And this master program is open to only South African, or you have students from other countries?
At the moment, it's our 5th cohort. It lasts 2 years. It is only for professional who work with children to have an honors degree. And because it is very in-house, practical, the core modules are clinical exposure. We run an infant mental health clinic. We see babies in the hospital, at NPOs. We are able to only offer it. We were originally only able to offer it in Cape Town, but then we are able to have partners with NPOs in other provinces of South Africa that we're able to offer that as a distance learning. And then they come to us for a theoretical week twice a year to the university. But, even that was not enough because there is only so much you can teach to a very confined group of people to go back. For us to make real impact, we wanted there to be education that was accessible and that was basically speaking to the messages we're wanting to give. And so we thought about that, and our group worked on trying to source information that we felt spoke to the message we wanted to give. That was, again, we say Afrocentric, but what we mean is contextually relevant. And we created an online short course, which can be done at your own time with 5 modules. And at the end of it, there's a quiz and there are particular tasks you have to complete. And so it's packaging, in a way, simple messaging, but also giving the opportunity to access other resources that we have curated in that way. And that we've been able to successfully offer across the country. And because there isn't a time limit to it, you can do it in a week or you can do it in 3 months, according to how fast you work on it. And you're not limited by being in South Africa. We've been able to offer it, I'm happy to say, in Nigeria to some students. We've had most recently an Ethiopian nurse do it, as well as in Tanzania. So I think that there is opportunity because it is online. And, if you have the internet and you can access that, you can do it. And so it's really exciting for us because it offers us an opportunity to demonstrate that innovation doesn't mean tech, although it needs the internet, but it's content that's important. And it's us questioning rather than just blindly following information that's been out there that hasn't necessarily been tested in an environment like ours. And again, I just want to say, it's not that we're saying we dismiss everything coming. The neuroscience, the background, the theory, that stands. But how we implement that and how we intervene really has to be questioned. And so we hope we're doing a little bit in that direction at the moment.
And this online course is only English?
It is only English at the moment.
Okay.
Correct.
So
opportunities.
We could translate it into French for all the Western countries of Africa. So
that would be great.
Yeah. And is it open to only? No, it's for everyone.
Anyone. So you could be a
public, and
you could be a teacher. You could be a mom. You could be a dad. You could be a student trying to think, I want to learn a little bit more. Anyone, really.
And I know it's important for you also. It's the psychoeducation that we give. Like prevention can be also what we teach in schools. And I know you're a strong advocate of mental health psychoeducation or psychoeducation in schools. How do you give those ideas around the world or around South Africa to help people know more about mental health, which is not like schizophrenia or bipolar?
So we are in baby steps, but I think what's really exciting. So one of the other caps that I wear is I'm the president of the South African Society of Psychiatrists at the moment, which is an adult organization. And so how do you get to the children? You speak to the adults. And how do you get people to listen? You meet them where they are. And so science communication is something I feel quite strongly about. And people who are interested are going to go and read journals, and going to read mental health booklets and watch those programs. But the bulk of the population is not going to do that. So we need to meet the population where they are. So what I've been trying to do in my term has been to try and make science communication more effective. And that means let's go onto the platforms where young people are, where old people are. So we've been doing a lot of Indigenous language interviews on radio, which is a huge medium to getting access to the population in South Africa. And we're doing things that people don't talk about. So things like, what do babies need? Why do men not cry? What do we do when we have demented grandparents who become infantilized and we don't want to put them in old age homes? These are questions that are so specific in this environment. If you were in London, for example, and if you had a grandparent that was dementing, we would say, let's look for the support, let's look for the old age homes. When you are in Africa, when you're in South Africa, we take care of our elders. The communities see it as a huge stigma if you remove an old person. So we collectively look, and collectively looking after a person who's dementing, for example, it's very difficult on the children in that home, as well as the parents who are now having to parent their own parents. So how do we get that message out there? Well, we communicate effectively and simply. And so we're trying to do topics like that through radio, through TV. I've done a few things on popular social media things like an Instagram live chat, with the health magazine, with the beauty magazine. Let's talk about body dysmorphism without only talking about an eating disorder. And let's talk about why we try to look like people in the West when we don't, Let's try and repackage that for children, for adolescents. But you can only do that if you meet them where they are. So we're really trying to work quite effectively in these psychoeducation campaigns to meet children, young people, and old people where they are. And where they are is not necessarily in a mental health office. At schools, for example, we've done some psychoeducation campaigns. Not a lot, but it's a work in progress, and it's about partnerships. We're trying to seek out partners with advocacy groups, mainly NPOs, who are seeing children for other things, non-profit organizations.
Okay.
Yeah, so where they are seeing children for other things, like, they're tracking stunting, or they're going to make sure immunizations are happening, or they're doing eye checks for children starting school. So that's the, fertile ground for us to be in and say, nurse, if you are weighing this baby and you're making sure that they've got the immunizations, how about you look at the mum and say, are you doing okay? How's your mood been recently? Have you felt that baby connected with you? So there are simple ways in which we can almost infiltrate everyday spaces, because mental health awareness is everyone's business, You're only going to come to a psychiatrist if you're lucky, a child psychiatrist, where, we have a terrible stat of we have 18 million children under the age of 18 in South Africa. Do you want to guess how many child psychiatrists we have? 35.
Wow.
So the chances of you seeing...
that was something I was thinking about. Where does she find time to do all this?
So,
where do you find your energy?
So the energy is about upskilling and making sure that other people think in a mental health friendly way. Because the idea that should be the realm of just the psychiatrist is a pipe dream. It's never going to happen. It's a fantasy if you think that every child who's anxious, who's feeling low, is going to necessarily see a psychiatrist. That's not going to happen. So yeah, we're constantly looking for, it brings me back to that word, innovative ways, clever ways to do that. Let's join that Insta Live talk. If somebody is talking about allergies in children on TV, we will send them an email to the show producer and we'll say, and do you not think that there is a mental health component to that? The distress for the parent or the child? Why aren't we part of that? And I think that's how you do it. You slowly invade the spaces where people start thinking about mental health like they should.
Yeah, and the lack of child psychiatrists, I think there's a lack of psychiatrists.
In general, yes.
In general, yes. all over. I know it's a problem in many different African countries. We've been interviewing people in other countries, and they say the same. Like one psychiatrist for maybe 2 million or 3 million or 4 million, 5 million people. So how do you get to those care if you don't have them?
You know, it's a double-edged sword, because it's also about political willpower, and it is about recognizing that mental health needs to be supported. I mean, if you think about it, we are competing with things that get more sympathy. You know, I'm sorry to say, but you would really not run up against a brick wall if you were trying to raise money for children with HIV, children with oncology, children with TB, children with disabilities, which also are not well resourced. But the minute you start with mental health, you know, people look the other way. Oh, there isn't money. We need to save lives, because it's not considered that, you know, emergency treatment. Yet every child with HIV, with TB, with oncology is very likely to have some mental health support that is required. And so it is more pervasive than we think, but there isn't that understanding, there isn't that political willpower, and there isn't that awareness for it. So part of it is talking when people don't want to talk about it.
Mm-hmm. Well, that's a little bit what we're doing, and I think mental health is still stigmatized and not in the front enough. Indeed. So that's what we're trying to do also with our summit, online summit on trauma, attachment, and resilience, to reach more and more people, and helping psychoeducation around mental health, and which is not, it's not a problem. It's not, you're not disordered,
Correct.
or you're just struggling with, and most of the time it's because of your trauma history.
Absolutely.
Cool. Well, thank you very, very much for this really amazing conversation, and for sharing what you're passionate about. And I really can see this passion, and hope you can really go even further on your
Thank
journey.
you.
Yeah, thank you.
We do this through partnership, so thank you for reaching out as well.